The role of Clostridium difficile infections decreasing rates within healthcare organizations. A focused area of quality within my organization that is currently not meeting organizational standards includes hospital-acquired infections, specifically Clostridium difficile infections, or CDI. CDI is a leading cause of GI illness, often caused by antibiotic therapy and hospital-associated conditions. This complex type of infection is often highly contagious and prolongs hospital stays, placing an immense financial burden on healthcare organizations and an immense physical burden on patients. CDI is a spore-forming bacteria causing mild, moderate, or severe diarrhea. Again, it's highly contagious with severe complications. 453,000 cases occur each year, with 15,000 deaths caused by CDI. Over the past year, our hospital-acquired CDI rates have been climbing, and our hospital stays for patients are being prolonged. Currently, there is a lot of attention on this specific quality issue, and there is an immense amount of pressure to improve the quality of care within my healthcare organization. The current reporting period this year, 0.84 or 51 reported cases, compared to the previous reporting period of last year, which is 0.35 or 22 reported cases. The SIR rate, or the standard index or infection ratio, is greater than 1.0, indicating that more CDI cases were reported than anticipated. The SIR rate is the standard infection ratio and is a summary measure used to track healthcare-associated infections at a national, state, or local level over time. It's a single metric. It's one number that can be used to make comparisons between the actual number of HAIs observed with the baselines of HAIs predicted. CDI can leave a detrimental impact on the patient and a healthcare organization. It can cause high-cost complications, readmissions, and mortality. High-cost complications can include pseudomembranous colitis, toxic megacolon, perforations of the colon, and then eventually sepsis. 25% of patients who suffer from a recurrence of CDI within 30 days of initial infection, which can cause a potential risk for more or future readmissions. And then for mortality, patients at increased risk for CDI include patients who are immunocompromised, which have an increased risk for mortality. These patients are HII positive. They are taking chemo, they're over the age of 65, and they have serious underlying issues, which can all lead to greater mortality within the healthcare organization if these patients keep getting this infection. The financial impact is also very outstanding. Healthcare-associated CDI places a high burden on healthcare organizations nationwide. Patients diagnosed with CDI have extended lengths of stays, which causes healthcare organizations to pay billions of dollars annually. It really does cause real and potential problems, and it can just impact health organizations negatively. Cost per case for CDI is estimated at $21,448. For length of stay, it's estimated at a range from 3 to 17 days, depending on how severe it is. Research said it normally is an average of 7 days. And then the total economic burden is approximately $4.8 billion annually. So current interventions that we're using to combat CDI is the nurse-driven protocol, the CDI interdisciplinary team, hand hygiene auditing tool, and then the antibiotic stewardship program. Responses of these interventions are below. The nurse-driven protocol improved specimen collection on day 1, 2, and 3. It also empowered nurses and gave them increased autonomy. The CDI team promoted collaboration, used track trends, and then found missed opportunities. For the hand hygiene auditing tool, we were able to identify opportunities and then focus on increasing hand hygiene compliance. An example of identifying opportunities with using this tool is finding out that hand soap wasn't near the doors, wasn't easy accessible for hand hygiene, or that the soap and stuff just wasn't getting stocked. So some of the barriers that we found when using this tool. And then lastly, the antibiotic stewardship program, being able to question antibiotic usage, using evidence-based practice, and then collaborating with pharmacy and giving nursing that ability to collaborate with pharmacy and giving the autonomy to really control their practice when they're at work as well. Evidence-based recommendations. The first one talks about CDI vaccines for prevention with high-risk patient populations. They're still currently doing clinical trials, but it's interesting to kind of read through the research that they are hoping that this would be a primary prevention method for really preventing CDI with these patients. The second one talks about peer review process for donning and doffing PPE, just having the right people involved in this process and holding people accountable and providing transparency and making sure that nurses are correctly donning and doffing PPE, and then having coaches and being able to really provide that real-time coaching and feedback. And then the last one talks about rapid diagnostic testing, being able to diagnose somebody within 6 hours instead of the 8 to 12 to 24 hours that we're doing now, which ultimately will decrease the amount of time that a patient is not on isolation, which could greatly impact infection control, and then being able to place the patient on antibiotics earlier, allowing them to get out of the hospital earlier. So there's always risk to innovative interventions, and we need to look at these risks as a positive and not as a negative, really being able to use these risks to impact care within the workplace. So CDI vaccines, research is still ongoing. Are they effective? It could be additional cost. Peer review for PPE could be additional cost. Classes would be mandatory, so it would affect staffing and productivity. And then accountability with real-time coaching. For rapid diagnostic testing, the research is still ongoing. We're not sure if it's effective because they're still doing clinical trials, and then additional costs with the organization. There's lots of roles for the nurse leader to be able to navigate through all these risks. So really being able to empower RNs and modeling our culture of innovation, leading quality improvement and innovation teams, and then implementing and leading evidence-based practice to impact care. For monitoring and documentation, the National Healthcare Safety Network is a national surveillance program focusing on decreasing HAIs. It kind of tells you where your problem areas are and then gives you best practices for how to improve outcomes within an organization. Track vaccine compliance and compare outcomes, auditing PPE and direct observation, and then placing observations in the shared drive for other nurse leaders to observe so that they kind of know where everybody is in this process. And then tracking contact isolation implementation and seeing if those outcomes really did impact, getting isolation on that patient earlier, and whether it impact the infection control rates and the ability of patients to really get the care that they need. There's always ethical challenges with everything. Vaccines can be controversial, especially because, a lot of people don't feel like they need to take vaccines. So this could impact compliance rates. Accountability with peer review PPE process and being able to place the right people to implement the process. And then the last one, rapid diagnostic testing, could take tension away from the patient, and nurses and providers could get so caught up with doing the testing that they could miss symptoms of something else that maybe they were experiencing, or just totally missing the patient altogether and being caught up with getting diagnosis as soon as they walk in the door. And then biblical perspective, by this everyone will know that you are my disciple if you have loved one another. John 13:35. Let each of you look not only to his own interests, but also to the interests of others. As Christian nurse leaders, we need to be able to look out for the interests of others and really innovate to be able to impact patient care and improve the quality of care within the workplace.